Thank you for joining us today. We have a few housekeeping details to share before we get started. This program is being recorded today, and the link for the video will be available in a few days. The recording will be shared via email and will be posted on our website. And for continuing education, credits will also be available. When today's webinar concludes, participants can click on the evaluation link in the description below this video window to obtain continuing education credits. So thank you and good afternoon, everyone. I'm Wanda McClain, and I'm the Vice President for Community Health and Health Equity at Brigham and Women's Hospital in Boston. And I have led a group of dedicated colleagues here at the Brigham on COVID equity in our community response team since the pandemic began here in March of 2020. I also serve on the governor's COVID advisory group with Reverend Liz Walker and attorney Michael Curry, and I'm pleased to be the moderator for today's panel. Before I introduce our panel, I also want to let you know that we'll have an opportunity for Q&A, and if you would please put your questions in the chat, and we'll try to get to as many of them as we can this afternoon. So it is my pleasure to introduce our panelists. We have another panelist joining us, and I will introduce her now so that when she joins, you will know who she is. So Dr. Paulette Chandler is seeing patients, but will join us as soon as she can. She is an assistant professor of medicine at Harvard Medical School, associate epidemiologist in the Division of Preventive Medicine, and a primary care physician at Brigham and Women's Hospital. She serves as the lead for community engagement and education for our COVID-19 vaccine trials at Brigham and Women's Hospital. Dr. Chandler's research focuses on understanding the connection between novel biomarkers generated through the omics technology and nutrition for cancer prevention. She is actively involved in several randomized clinical trials and observational studies. She serves as a cancer endpoint. She serves on the cancer endpoint committee for the vitamin D and omega-3 trial and the cocoa supplement and multivitamin outcome study, or COSMOS, and serves as the medical and safety officer for COSMOS and the Chronos early estrogen study, which is known as KEEPS. I am thrilled to have also joining us today Reverend Liz Walker. Reverend Walker is the pastor of the Roxbury Presbyterian Church in the heart of Boston, where she leads the Corey Johnson program for post-traumatic healing. Named after a promising young member who was murdered in 2010, it is a faith-inspired, clinically supported, community-based program that addresses the epidemic of post-traumatic stress in neighborhoods too often that are overrun by violence. A 2005 graduate of Harvard Divinity School, Reverend Walker has long been actively involved in healing the world. She has helped found the Jane Doe Safety Fund, a multi-million-dollar state and anti-violence initiative that works on policy and supports domestic violence shelters and safe houses around the Commonwealth. She spent 11 years as a humanitarian working in South Sudan, one of Africa's most troubled countries. Reverend Walker became a minister after a television career spanning 21 years as the city's first African-American news anchor on WBZ-TV. Reverend Walker has taken a lead role in vaccine education for communities disproportionately impacted by COVID-19, serving on the governor's task advisory group for COVID vaccine distribution. Thank you for joining us, Reverend Walker. And last but by no means least, it is my pleasure to introduce Michael Curry. Mr. Curry was recently appointed as the president and CEO of the Massachusetts League of Community Health Centers after previously serving as the deputy CEO and general counsel and senior vice president of the government affairs and public policy there. Michael led local, state, and federal affairs and public policy for the 52 community health centers throughout Massachusetts, serving over 1 million patients in over 300 practices. In November of 2010, Michael was elected to the presidency of the Boston chapter of the NAACP, the first chartered branch, which was established in 1911. He successfully executed a strategy to strengthen and influence the voice of the NAACP in Greater Boston by rebuilding partnerships and re-engaging city officials. In 2014, Michael was elected to the national board of the NAACP Board of Directors, becoming the first representative from Boston and New England to serve on that national board in over 35 years. He was reelected in 2016 and 2019. Michael is working on various aspects of the COVID-19 pandemic. He serves on both the City of Boston's COVID-19 Health Inequities Task Force, the Massachusetts Department of Public Health COVID-19 Health Equity Advisory Group, and the Massachusetts Public Health Association's Equity Task Force. Michael, thank you for joining us this afternoon. So let me direct the first question to you, Michael. It has been often stated that COVID-19 has laid bare in plain sight the inequities that have existed in our nation around health and health outcomes. Can you put what we're experiencing today in a historical context for our audience?
Thank you, Dr. McClain. I want to start, I think, as all of us have probably been glued to our TVs this morning, by acknowledging the inauguration and the historical moment of our first Vice President, woman, a person of color, African-American, Asian-American, and I want to just applaud that moment as we get ready to talk about history as a part of this taint of race in our healthcare system. Acknowledging when we've cracked the ceiling is an important part of this conversation. There's a William Faulkner quote that I love and is appropriate to really tee off this conversation. It's, "The past is never dead. It's not even the past." And I think when we talk about the taint of race in our healthcare system, that leads to this moment of continued racial inequity and the impacts of COVID-19 that are being borne disproportionately in communities of color. We have to start arguably at 1619 with the arrival of slaves. We're having a racial reckoning in the country right now, where people are now, for the first time, I would argue, in our nation's history, digging back into those dusty documents to understand the rich history and the trauma and impact of racism in our American story. And that starts with the arrival of those 20 or so Negroes on that ship in 1619 in Virginia, and a series of generations that had to deal with health inequity, experimentation, exploitation throughout slavery. You can't get to where we are now without starting there. W.B. Du Bois had a quote that said, "Nothing can be solved that can't be faced." And as we who work in and around healthcare, we've never truly faced that taint of race in our healthcare system. So I walk through very quickly the abuse and neglect of slaves. I would walk through and lift up, just for this conversation, Dr. Marion Sims, who for all of our lifetimes has been identified as the father of gynecology, one of the leading physicians in American history, who broke ground in treatment of women and the conditions that they faced in pregnancy. But the challenge in that is that his story is not fully told. You may have watched just 2 years ago when they removed his statue from Central Park. You may have seen stories about his recognition in statues in Alabama and in South Carolina. This physician, Dr. J. Marion Sims, gained his reputation, his acclaim, from experimenting on Black women slaves, without their consent. Without anesthesia, which had been discovered and was being used pretty broadly at that point in the 19th century. He did not use anesthesia, leading to today's conversation around the myth that Black people don't experience pain and that we can withstand pain. So you had Dr. Marion Sims, and he's just one example of many doctors who use that institution of slavery to advance medicine. We don't tell the story of Anarcha or Betsy or Lucy, the three women who were the most prominent women that he experimented on during that part of our history. We don't talk about the denial of healthcare post-slavery as you entered Reconstruction and those millions of Africans, former Africans, now African-Americans, who were now freed. Many of them were not. They were still subject to their slave plantations, but many of them freed and didn't have a job, didn't have a home, didn't have healthcare, didn't have the supports that you need to live healthy lives. Entering the 20th century, you walk through the taint of race in our healthcare system, segregation, Jim Crow laws that were now dividing Black and brown citizens from access to the same opportunities and care that white citizens had. You can't have that conversation without talking about the 1930s, the introduction of the Tuskegee syphilis experiment. Those 600 or so Black men who were brought into that experiment, 399 or so were involved in that experiment, had syphilis. We had at some point years later a treatment for syphilis, but they were denied the treatment for their syphilis and allowed to be watched until their death. That is history we've not even tapped into to understand how experimentation on African Americans from 1932 to the early 1970s was allowed to exist in this country only because you have disenfranchised African American people who did not have the same rights, did not have equal access, and did not have the protections under the law. You'd have to talk about Henrietta Lacks and the reproduction, the taking of her cells without her consent. And now we acknowledge the medical advancements that came from stealing her cells, but that her family hadn't been compensated, that she didn't have an opportunity to even consent to that when she died of cervical cancer. So then we walk into the early 2000s when Dr. McClain and Reverend Walker, folks like my mother and other elders would say, well, doctors don't treat us the same. They don't offer us the same medicines because they think we're drug addicts, or they send us to amputations when there's other courses of treatment. And you sort of shuffle by those folks on the street corner thinking that they're just militants. They're conspiracy minded. Until in 2002, the Institute of Medicine published a report called Unequal Treatment. It took the Institute of Medicine to validate what many Black activists had been saying for generations about our healthcare system. So Dr. McClain, as you think about all the abuses in our system, you think about sterilization, the forced sterilization of African-American communities. If you think about the denial of health insurance, 46 or so million people did not have health insurance before the Affordable Care Act. Many of them were Black and brown, and we know what happens when you don't have health insurance. Way before we understood patient-centered medical homes and primary care, Black and brown citizens were walking in emergency rooms, well advanced in their disease and their conditions, and not getting primary care, but getting episodic care in the emergency room. The work of this conversation is around what is the taint of that segregation that kept us from getting medical care up through Medicaid, which people don't identify, but it was a civil rights bill. Medicaid and Medicare desegregated hospitals and provided some access to millions of African-American and people of color and immigrants who would not have had health access but for the passage of Medicaid. So as we open this conversation up, we can't help but to revisit history because it's not the past. We talk about experiments, vaccinations and clinical trials. There's a reason why Black folks are hesitant. When you talk about our distrust of medical systems, there's a reason why we're distrusting of medical systems. So I challenge us as we tee off this conversation today, embrace that history. We have so much research to do. So if you ask me to take a vaccine, I need you to know why I don't want to take it. I need you to understand that and understand our history. So Dr. McClain, that's just a quick walk through, a quantum leap, as I say, through history, but there's so much for us to talk about.
Thank you so much, Michael, and thank you for giving us that sense of that expansive history in such a short period of time. And I'd love to come back and dig a little deeper. But what I heard you talk about also is the trauma that people might feel from going through that history, from experiencing that. And that leads me to a question for you, Reverend Walker. So much of what your work is about is leading around the impact of trauma on communities of color. And I'd love for you to be able to talk to us about how you see that impacting us during this, what the impact of trauma is on our populations, in particular Black and people of color populations during this pandemic.
Dr. McClain, thank you so much for letting me be a part of this conversation. I am honored. I'm honored to join your global audience, and certainly Michael Curry is one of my heroes, and I can't wait to hear from your doctor who's going to be joining us. I used to think about trauma because this is what I learned as a reporter and as a member of this country, that trauma was connected to war zones in faraway places, and soldiers were exposed to mass murders and killings and that kind of thing. I thought that up until the time I heard and learned about Corey Johnson. Corey was a young man who belonged to our church, Roxbury Presbyterian Church, in the heart of Boston. He seemed to have a bright future. He navigated the inner city like every other young man. And life looked promising until the night he was gunned down in 2010, not far from the church. His murderer was never found, and his family was wounded emotionally and psychologically and spiritually beyond words. His name was then added to a long and growing list of young people who seemed to be killing themselves all over our neighborhood. We began a program named after Corey that was trying to address the issue of what survivors of homicide were going through. I used to, as a news reporter, I used to look at the homicides as a social problem in the community. But after becoming a minister, I saw it through a different lens. After the community vigils, after the meetings with the mayor and the police department, there were other steps that had to be taken to address some of the problems of the survivors of homicide. The more we looked in the neighborhood, the more pain we saw. It became clear that we needed to begin to take an intentional look at the mental and emotional toll that violence takes on people who remain. In many ways, our neighborhood is like a war zone. You do not get over the death, a violent death of a loved one. There's no closure, there's no sense of peace. Violence robs you of your safety, your trust. You can become isolated and disconnected from your neighbors and your sense of purpose. While some in the field of psychology will see these as clinical issues, I see them through a spiritual lens. So we began monthly community gatherings that allowed people from all over the neighborhood the time and space to talk about their pain, to tell their stories, to lift up their loved ones who were viciously snatched away. We thought at the very least it would offer a release valve on some of the pain and rage that accompany these kind of tragedies. But after talking with many mental health partners, we learned there was also the possibility of some other kinds of healings. What I did not know and had to learn quickly was that you cannot talk about the violence in the streets between gangs or connected to drugs or abusive relationships in a vacuum. People would come in and they would start talking about their distrust and fear of the police, their distrust of the criminal justice system, the fact that so few murders were ever solved in the neighborhood, the lack of control or resources in public schools. They talk about the loss of jobs, poverty, their inadequate access to healthcare, all connected to this violent episode. It was as if everything had turned against them, a sense of betrayal from every system that's supposed to be supported. So we learned that trauma was not just about a violent individual act, that people are traumatized by systems and structures and racism and history. I have read many books that define trauma only in the context of wars, and that say that we can't afford to get too broad in the definition. But I am learning to trust what I see and what I hear more than anything. Our definition of trauma is an event or series of events or circumstances experienced as harmful or threatening that have lasting effects on functioning and well-being. trying to untangle all of the personal, the social, the structural threads that are a part of any one case of violence in our community was like trying to untangle a maze of yellow police tape. Everything's all stuck together. Everybody is touched, everybody's impacted. It turns into what I call collective trauma, the collective wounds of entire communities. So our meetings were increased from once a month to once a week. We began to study the connection between poverty and trauma, race and trauma. And one of the most compelling lessons I learned was how all of these systemic, historical, interpersonal wounds were affecting people's health. I think back with sadness and shame on how I first arrived at the church and admonished my membership to simply change their eating habits. That macaroni and cheese, those fried foods, that fast food were not good choices and were causing diabetes and high blood pressure and heart disease and leading to much more serious problems. I preached that we need to change our behavior, but it didn't take me long to realize how complicated that part of the process really is. Good health is expensive. If you are poor, you are lost as far as good health goes. If you live in a neighborhood where the food in the closest grocery store is not necessarily the freshest or the healthiest, if transportation is an issue and getting to a better store, if you can't afford the fitness membership at the local Y or the boys clubs, if you feel unsafe about doing exercise in other places, and if you go to a clinic or a community health center, or even a hospital, you may not have the best or most productive interaction with the person on the other side of the desk. You may run into a partner who dismisses your complaints. You may run into a person who looks down on you, or your perception is that person is looking down on you. You may run into people who just ignore you. You may deal with a provider who is as traumatized as you are in this neighborhood. He may be overworked, underpaid, underappreciated. People are traumatized and re-traumatized every day trying to get healthcare, trying to get support. We talk about this in terms of what happened in Tuskegee, and we should. We talk about trauma in terms of what happened to Henrietta Lacks, and we should. But people are traumatized every day in their local health support systems. So we're talking about people who are experiencing things that are extremely impactful on their mental, emotional, spiritual, and physical health. And this was all before COVID struck. This was before George Floyd was killed. What now? The work we have been doing at our church is more important than ever, we believe, because pain and fear and rage are now compounded in unimaginable ways. Violence is up, staggering job losses, financial instability, food insecurity, and all of those things affect people mentally, emotionally, and physically. We all associate the distrust of the nation's healthcare system with history, and that's fine. But the bigger part of the problem is the perception and the feeling and the impact of those everyday injustices. I accepted the governor's invitation to be a part of this working group with Dr. McClain and lawyer Curry because I wanted to make sure I'd learn as much as I could about the safety and efficacy of the vaccine. We now have monthly town hall Zoom conversations to inform people about the vaccines situation. We've invited important people to talk to these people in my community. But what I'm learning is to really start listening to the people in the community, talk about the reasons that they don't want the vaccine. The distrust over the COVID vaccine is not based on hysteria. People are asking very valid questions. Early on, one woman asked me, how could she be assured that she was getting the same vaccine as everybody else? And at first I thought, of course you are. And then I heard one of our, at the time, lawyers for our government officials say, well, I'm getting a different treatment because I'm a celebrity. My point is that we need to really work on the notion of mental health in this country. It is impacting everything in this COVID epidemic, in this epidemic of injustice around the world. And it is important to take that very seriously. We have a problem, and one COVID broadcast, one town hall, one event with Dr. Fauci is not going to change it. It's going to take some hard work, and it's going to take first the realization, the confrontation, and the admittance that trauma is a serious problem, not only in my neighborhood, but around the world. I look forward to hearing questions and discussing more of this with you. Dr. McClain?
Thank you so much, Reverend Walker. And I want to thank Dr. Paulette Chandler for joining us. And I do want to correct one thing. I am not a doctor. I work in healthcare, but I am not a doctor. My parents would be proud. So thank you, Attorney Curry, for promoting me. But I want to correct the record. We do have a doctor in the house, however, in Dr. Paulette Chandler. And Dr. Chandler, I read your bio so people know who you are, and we're so glad that you're able to join us. And Reverend Walker, I just want to say thank you for really expounding on the impact of trauma, current day trauma, as well as the historic trauma that Michael talked about. But, Dr. Chandler, I'd love for you to talk about your experience leading the vaccine trials, community engagement efforts, and the impact of this trauma and this mistrust, and the legacy and the current day treatment that Reverend Walker talked about, that people are experiencing, and how that impacts their willingness to participate in trials and some of the hesitancy we're seeing around the adoption of the COVID vaccine.
Thank you. And I agree with all that Reverend Walker has discussed in terms of the trauma and distrust. And when we started working in the community with the engagement of the community around the vaccine trials, our first concern was, we know there's distrust. People have had a lot of injuries throughout the system, and we started engaging in the community around the vaccine trial participation in the backdrop of George Floyd, Breonna Taylor, and of course, as members in the community kept on saying, 2016, 2016. So we worked in the setting of this distrust, but we worked with our partnerships that we already had established in the community and sought to develop new partnerships. And I think one of our spotlights was the Brookside Community Health Center, where that center has been in the community for years. They have summer job training. They were already meeting the needs of the community from the perspective of addressing food insecurity, providing food, helping people deal with home evictions, housing evictions, as well as doing voter registration and census, helping people fill out the census. So when we approached those individuals, they were quite willing to sign up for the participation in the vaccine. Now, of course, participation in a vaccine trial is a big leap. You're healthy, and you're putting yourself at risk for having some complications that you have you cannot even begin to imagine what could happen. But at that time, the stakes were high. They still are high. We have over, we're hitting 4,000 deaths a day, and we've lost over 400,000 individuals over this COVID pandemic. So individuals in that community of Brookside that were coming there for COVID testing, they stepped up and they said, yes, I want to be a part of the solution. Now, in terms of other communities, there was resistance. When I would even talk with Black members at my church, they would say, oh, no vaccine for me. I'm not going to be a guinea pig. Even some of my patients had that same reservation. Why would I want to be experimented on? Don't you remember Tuskegee? And of course, then others would say, well, Mom, my son, we have the mass incarceration. We have current day slavery going on. But others, I think of one of our participants, he said, he saw the advertisement about the vaccine trials while he was watching the news. He said, what? I didn't even know there was a trial going on. And he started Googling around. He said, I've got to find a place where I can get started and participate in this trial. And so he Googled and he found the Brigham and he called, I want to participate in this trial. And he signed up. He said, I want to do all I can to help get this study completed. And he said, do you have any brochures? I want to go up and down the T-stops and everything. It was amazing, his fervor. And he called his parents, his relatives in New Jersey, said, guess what? I'm going to sign up for this vaccine trial. And they said, are you crazy? They said, and so he said, no, you see all of our people dying. I want to do something. So he was a true champion of the trial. And when others at his store where he worked heard about it, they came in. In fact, one of my patients came in. And so that fervor and enthusiasm that he had for the trial inspired many others in the community to say, look, I want to step up to the plate. Now, that doesn't mean that we can ignore the trauma that's happening. There are people that have lost family members, they've lost income. They are still dealing with the trauma of COVID. They still have shortness of breath or, other damaging effects from having had the infection. And I look at people that as they've engaged in these discussions in the community and with one-on-one with people that participate in the vaccine trial, some of them have moved to the middle. I think of one lady, she works in a group home, and she said initially when those vaccines arrived, and they said, oh, we're willing to vaccinate the healthcare workers here. She said, oh, no. And then she said, no, I'm going to do it. And 3 of them out of the 23 individuals there agreed to do the vaccine. And then when her daughter came home from college, she works in a nursing home, when she's on vacation, she goes, I want to do this too. And so as you see people stepping out in trust, wanting to be part of the solution, it influences others. Of course, we have much to do. And as we engage in the community, we've listened, we have more listening to do. As I tell people, if you're not gung-ho for the vaccine, you're not willing to take it, keep on engaging in the discussions, dig into the research yourself, attend as many sessions, share your concerns, your fears with your healthcare workers, as well as with your community workers, your community members. And I find that those discussions are often rich, and it often comes up with people thinking, what else can I do to be more active, more politically active, more socially engaged around trauma, as well as, legislating. Some of these things really do have to be legislative. And so we were successful. Success can be measured on many different levels, but we were successful in terms of engaging the community in discussion. We worked with Sportsman Tennis Enrichment Center, where we already had footprints there. I'd done cooking classes in the community for a couple of years there, but other outreach efforts. We had children's educational programs there, and that was one of our COVID testing sites. So we're continuing to engage with sportsmen around addressing these issues and discussing these issues of social determinants of health. Now, in terms of the trial results, we, got about 10% African-American, Black, and about 25% Latinx. Now, we weren't only reaching out to those communities because people say, oh, are you targeting us? No, we wanted everyone to be a part of it, but especially those that are at high risk for getting complications from the infection. So we reached out to first responders too, EMT, policemen, and teachers, and they stepped up also, willing to be part of the solution. And so now we've completed, of course, now we have emergency use agreement approval for the vaccine, and people now saying, well, were there people in those trials that look like me, that had my issues? And we can say, yes, there were some. Could we have done better? Yes, but we're happy that we got those that did decide to enroll, given the backdrop, 2016, mass incarceration, police violence, brutality, that's ongoing as we speak today. So what do we need to do to move forward? We want to keep on engaging in these conversations, but also come up with active solutions and realize that this is not going to be an easy fight. It's been going on for years. We know that the solutions to these traumas are not going to happen overnight, but we're willing to engage and work as partners with our community members to hear as well as to act.
Right. Thank you so much, Dr. Chandler. And we had a question in our chat, and just for our panelists, we're the only ones who can see the chat. So the questions someone asked Dr. Chandler was, when you referenced 2016, what exactly did you mean by that? And Attorney Curry had a response, which I can read so that our audience can know. The 2016 that Dr. Chandler was referencing is likely a reference to the presidential election in 2016, and I'm assuming that's correct. Is that right, Paulette? And the racial tensions that stoked and exposed, and that heightened the Black and brown residents' distrust in our vaccines under the prior administrations. So I just wanted to make sure that everybody saw that. Residents felt like the politicization that they saw play out would also impact the vaccine, its efficacy, and its safety. Is that what you were hearing, Dr. Chandler, from some of the participants?
Yes, and they wouldn't even go into all the details. They would just say 2016, and that's sort of like their summary statement. And that's unfortunately what we experienced.
Right. And so I do want to go to the chat, and I want to ask our audience to continue to send any questions that you might have. There was one of our first questions was, it's interesting to learn if there's any predisposition of trauma of the impacts of the successive treatment / vaccination outcomes. So outside of the healthcare institution, is there any impact that trauma would have on the success of the treatment and the outcomes from the vaccination, is how I interpret that question.
I mean, of trauma, if there's mental health issues, of course, that comes along with trauma. It can make people more anxious after they receive the vaccine. They can have heightened immune response. They could have heightened pain, because we know that pain perception can be heightened in the setting of trauma. Or, so there are a host of different ways that you can imagine that the mind-body connection could influence your response. And that's something that, as a person, if you decide to receive the vaccine and you have that history of trauma or mental health issues that are active, anxiety, depression are exploding as people continue to balance. How do you live in a world where you can't move around as you used to move around? You've lost income, you've lost family members that were supporting you. How do you navigate that? And those are tools that we are working on developing, each one of us, each day.
Great. Reverend Walker, did you have anything to add?
Dr. Chandler did a great job in explaining that. I was just going to say, I think one of the issues to resolve that, or to begin to look at it, is to talk about this, which is what we're doing right now. To talk about the issues, to admit, that there are fears, that we're all feeling a little crazy right now. So it's through that exposure, and confronting it, that I think you can begin to work on those issues.
Great, thank you. Another question that we have in the chat is, agree, we should encourage our patients to engage in information gathering. However, and I think this is for everyone, it's not only directed at Dr. Chandler. However, how can we prevent them from getting caught up in misinformation and conspiracy theories that are rampant online? Michael, how about if I turn that to you for that one?
Yeah, I think, we have this issue, not just in healthcare. I mean, we are in the generation of fake news, that you can forum shop. We use that term in the legal profession. You can search for whatever you believe and find it online, even if it's not the truth. So people are forum shopping for their truth. And the reality is you talk about this pandemic and this, people believe, and you could still find online, that there is no pandemic or that doesn't impact Black people, or, just a whole bunch of myths that are absolutely ludicrous. And the reality is that the vaccine is facing the same challenges, whether it impacts, and Dr. Chandler can address all those issues, whether it changes your DNA, whether it's effective or not, and whether it's safe or not. There are so many stories that are out there, and then we have to do something with it. I think you're doing, Wanda, and Reverend Walker's been doing, is dispelling the myths. And Dr. Chandler, we got to inundate our communities and the general population with an awareness of what the science is. But here's what I often tell people. When we go in to get our diabetes treated or our heart disease treated, our AFib or cancer, we probably understand 5 to 10% of what the doctor tells us. There's a lot of deference we give to the medical profession. There's no way in the world we can understand it all. So we have to rely on our providers, and we need folks like Dr. Chandler, Dr. Thea James, some of my heroes and sheroes that are doctors in this profession. The data is telling us that people trust doctors the most. They can hear from a superstar, an athlete, they can hear from an elected official, but the number one person that we want to hear from, particularly in communities of color, are providers. And we need them at the front of the bus explaining to folks why this is important. And I think if we do that, lifting up the voice of Dr. Chandler and others, then we'll be able to combat some of that that fake news that we're hearing online.
Great, thank you, Michael. And Dr. Chandler, there was a question specifically to you in the chat, and it is: is Dr. Chandler's 4-point response to sum up why to get the vaccine when my patients ask? So I'm assuming this is from a colleague, a fellow physician.
So number one, it will help prevent symptomatic disease. We know the vaccine is 94 to 95% effective at preventing symptomatic disease. Number two, it helps prevent risk of developing severe infection. 3, we have the hope that not only does it prevent symptomatic infection, but it should hopefully, like other vaccines, help stop the spread of the virus. And number 4, that it will help us hopefully get out of the pandemic in addition to the other strategies: wearing a mask, practicing physical distancing, hand washing, contact tracing. So those are the reasons to get the vaccine. Not that it's a cure-all, but it's part of the solution.
And a related question, and I'm sorry to bombard you, Dr. Chandler, with these questions, but there's a question about how do we counsel our communities in regard to the side effects of the vaccine?
Right. So we usually describe it as the side effects being associated with similar to a flu vaccine. There'll be some soreness at the arm, the muscle where it's injected. You might have some fatigue, headache, but most people, the biggest one is soreness at the site of the injection. And for Moderna and Pfizer, those are 2-dose vaccines. Some people say that the second injection is a little bit worse than the first in terms of the symptoms experienced. But some people, they have the vaccine and they sail through. They have no side effects whatsoever. And I can tell you a number of my colleagues have had both shots now, both vaccinations, and they said it was like nothing happened. Except for soreness, muscle soreness at the site of the injection. But other than that, no fever, no fatigue, no headache. I mean, I had my Moderna injection and I just had soreness in my arm for 3 days and then I was fine.
Wanda, if I could, because Dr. Chandler's point on that, I think people are calling me as well, Dr. Chandler, around this issue of what they saw in Norway, the deaths in Norway, the episodic, very isolated adverse outcomes after taking the vaccination. Can you speak to that as well? Because I think that's a burning question.
Right, it is. I know. I had done a talk at a church, and when that came out, the people were emailing, "Oh, did you see Norway?" But remember, those that died in Norway, they were frail and elderly, and we're going to see there will be people that will die, but it may not even be related to the vaccine. However, they are investigating the cases of those frail elderly individuals that died in Norway, 23 individuals, to see whether they were related to vaccine complications or not. However, we know that age is one of the biggest risk factors for death from COVID. So we have to balance the risk of a complication from a vaccine versus the risk of severe complications. And people that are older and that have multiple health issues, diabetes, underlying lung disease, underlying diabetes, are at increased risk for severe infections and, just complications from infection.
Dr. Chandler, if I could just add one more point. we also take a lot of what's going on for granted, I think, in this social media, mass media world. But this is unprecedented, right? This notion of vaccine, a vaccine for millions of people all over the world. So aren't we going to see some kind of outlier issues pop up?
Yeah, we will see some outliers. And remember, this is the closest thing we've seen to this in our lifetime is the polio vaccination, where there were mass vaccination campaigns, people lining up all over the place, and there were few side effects from the polio. There were few, but overall we no longer see polio in our country now. And you see, like in countries like in Nigeria, northern Nigeria, where they don't necessarily vaccinate for polio, there you see outbreaks of polio. So we know that the vaccine strategy can eradicate infection where we don't see the debilitating complications from infection that we see when we're not vaccinating. So there's always, even with the polio vaccine, we did see some side effects to that too. But overall, the mass benefit outweighed the potential harm from the vaccine.
Thank you. And, there's a question in the chat about the global context of vaccinations, which I think is an important one for us to discuss, because some poor countries are not getting equal access to vaccines. And actually last week, I was on another webinar on this topic, and one of the presenters was the head of the CDC for the African continent, and he said that there are no vaccines yet on the continent. So how do we talk about this in a global context? How do we think about equity in vaccine distribution in a global context? And I'm not sure if who would like to take that question.
If I can chime in first with a thought. So one is we haven't even had a global conversation around the disparate impacts of this COVID-19, right? And we know, if you didn't know, now you know, that the same disparities that we're seeing play out in the United States are playing out in other countries. So COVID-19 in London and throughout England and France doesn't, I believe, collect racial and ethnic data. But for those countries who collect it, we're seeing the same thing. So this is not new, right? We talk about it's not new in the United States. It's not new across the globe. I think about, and I don't know the depth of this, maybe Dr. Chandler knows the story of Pfizer with meningitis study in Africa as a major controversy around how that may have been a taint on our clinical trials and the exploitation of Africa as a place to do studies without the regulatory oversight. So this is a global conversation around disparities, and the vaccine is going to be challenged, one, by even reluctance of Black and brown folks across the globe to take the vaccine. But then to your question, Wanda, also on the distribution of it. We know that disenfranchised, poor, marginalized countries will not have the same access to this vaccine as the United States and some other more developed countries. That should be we fortunately are not isolated, despite some prior administration philosophy on this. We don't have an isolationist view as African Americans. We particularly can't have that. We are connected to our brothers and sisters across the globe who will also have challenges getting access to this vaccine.
Right. And even when you think about access, I mean, people that live here in the US but are from these African countries, many of them expressed to me that they're concerned about whether their government, when the vaccines are delivered, whether they will actually be distributed, equitably, but also whether they will change out, vaccinate them with something else and save the real thing for the elite groups. And then others, I mean, the conspiracy groups on these different platforms from these African countries are amazing. They're saying that, it's just a ploy to exploit Africa, again, charge them money for these vaccines and then give them something false. So, I mean, there's just a lot of concern. And even I think about people here that are from these African countries. Some of them said, I don't want that. I wouldn't take it with a 10-foot, I wouldn't take it if someone paid me $1,000, because they're concerned that there's just been too much emphasis on this pandemic when their countries have not been severely affected. At least now, like in Nigeria, they're starting to see more deaths, but other countries there have not reported deaths. But of course, we know that some of that is reporting just they don't have access to testing, they don't have access to care. So if someone dies in the village, you don't even know that they have died because they don't even hit the healthcare system. So that, I mean, it's complex when you start thinking about, I'm thinking specifically about Africa because I have strong ties there, but it's the same in other countries too.
Right.
The continent of Africa, I should say.
Thank you. And you know, so clearly inequities are not limited, obviously, to our country, but the wealthier nations' ability to purchase vaccinations and probably over-purchase for their needs is one that that we should all be concerned about. So, Reverend Walker, there is a question that's directed at you in the chat, and it says, Reverend Walker, can you speak on any health promotion campaigns that may exist to make participation in vaccination safe and sexy, popular, proud? They said lack of terms. They're trying to figure out ways to make it resonate with folks, like voting, wearing a proud badge. So any thoughts on how we can make this, you know, proud and sexy, safe and sexy?
I have been contacted by one of my friends from the Celtics. He played in 1986, and God, I can't think of his name now. But anyway, the campaign that he was thinking is Cedric Maxwell. Forgive me if you're anywhere around and you hear about this. Cedric Maxwell is working on a campaign for basketball players, both those of the past and those now. And they're saying, take the shot. And I thought that was brilliant. And that was simple. And that you get a Michael Jordan, or you get a LeBron James, or whoever the real stars are. And it's just take the shot. That's being part of the team. And so I know he's working on that. And I think it's going to take that, but it's also going to take the people that people know in the community. So it's going to take the big stars, you know, I'm sure that the singers and the movie stars and that kind of thing, but it's also going to take your pastor and the head of your community health center and your doctor, people that you know. I think it's all hands on deck to get this thing moving is what I'm hearing. And I think you guys would agree.
Yeah, I think that's right. And there was one other question, Reverend Walker, that I did want to give to you, and it was another global question about trauma and the impact of trauma. How do you see that? Is the work that you do around trauma, can it be applied on a more global scale?
Absolutely.
I think that's what that question means.
Right, absolutely. The work that we're doing that comes out of a church, comes out of a community, is about empowering the community. We're not trying to take the place of mental health care workers or psychiatrists or psychologists. We're trying to supplement that. So we think that this work is already going on in places in African nations and in places in South America and Central America, where groups in the community are trying to help each other face the tragedies, because really there's not much difference in some ways of the experience of a war and the experience of what's going on with the police brutality and the violence in our communities. So we think this is the kind of model of a community-based program to surround people who have been, who have suffered from trauma, and to just hold them, to hold that pain. We think that's a model for any place all over the world. It's not a franchise. It could be replicated. And our program is being replicated in about 10 communities right now.
That's great. Thank you. Thank you so much. So, one of the questions as we begin to close out our fabulous conversation this afternoon, we've talked about some strategies for promoting, for decreasing vaccine hesitancy. And we also talked about a lot of the other health issues that impact Blacks and people of color in this country. And if we wanted to go further, we would talk about the global impacts, but let's just stick with them here domestically. what are some of the strategies that we should deploy to be able to improve the health of these populations, Blacks and people of color and other marginalized groups, to improve their health outcomes and make them healthier beyond the pandemic, beyond the vaccination? Any thoughts on that? And then we can do this round robin.
Well, maybe part of what I think, and I mentioned this earlier, the racial reckoning that's going on in the country right now, and it's police reform, it's housing, it's education, is also in healthcare, and health inequities is the focus of many advocates right now. It was the caboose, I would all call it, of the civil rights movement, right? There was so much focus on desegregating lunch counters in schools that we didn't do enough to focus on the death rate, the disproportionate death rate of people of color, particularly African Americans in this country, which was the taint of race in our healthcare system. But I would say right now, I serve on at least 4 task forces that are all focused on that. We now have the Health Policy Commission here in Massachusetts turning its attention to that. Our data organization, which we call CHIA, focusing on that. Health centers are using its data and starting to look at what we can do outside of the 4 corners, the 4 walls of our buildings. There is a focus on transparency, meaning dashboards that track health disparities and that we pay attention to those numbers now. Data, can we collect the data? How are we using the data? And we've not done a good job in this country of collecting data. COVID-19 revealed that when we couldn't give you an accurate count of how many Black and brown folks were dying. And then we have to have the courage to advance policy that actually changes those circumstances, the housing, the education, the environmental injustices that we see, not just in Flint, Michigan, but across the country, that make people sick and then treat their teeth, their mental health, their eyes, and all the other services that, quite frankly, African Americans and many others are not getting. Last but not least, we're still not insured at the rates of white Americans in this country. And when you don't have insurance, you have bad health outcomes because you don't have someone who's engaged in your health care. That's a lot, Dr. Chandler and Reverend Walker. That's a lot to do, but I think if we're all focused on it, I think this could be the movement to change that.
Great, thank you, Michael.
I just wanted to add one quick thing that I had heard in listening to people. Pharmaceutical companies make billions of dollars and are bringing in the money raking. They're win-win for them. We're so thankful that they've come up with these ideas and with these vaccines. That's wonderful. But why not use this moment to get pharmaceutical companies and big money corporations more engaged in assurances to the community that this is not just a one for thing, that you're going to see this through and find ways that you can support communities. What assurances does a person who doesn't have a primary care doctor have that down the road, if something goes wrong, where does he go? How does he get health insurance? So we're saying one thing that we could be doing now is putting more pressure on these companies that are absolutely making money out of this and get them more. We thank them for their work. We're not, knocking that, but there's more that they can do right now to begin to change systems.
And in addition to that, thinking about how the companies can provide employment, training opportunities, as well as hiring individuals from these communities of color that have been so critical for getting their vaccines approved, and reducing drug costs. Insulin's outrageously expensive. Diabetics, communities of color are disproportionately represented among the diabetics. So improving drug care access. And
we need more Dr. Corbett's and Dr. Chandler's. We need to invest in a pipeline of primary care, a pipeline of researchers, of epidemiologists of color to be at the table. We've cheated ourselves because there's a young Black girl sitting in a Southside Chicago school right now that could find a cure for cancer, but we may never know who she is because she doesn't have the academic rigor and supports that she needs. Dr. Chandler, Dr. Corbett, who was a part of the team to discover the vaccine, are testimony to that.
Absolutely. So I want to thank you all. I wanted us to end on a hopeful note, and I do think that we achieved that goal through your comments about how we can begin to not only imagine a different future, but actually create a different future for not only for vulnerable populations, but for all of us in this country and globally. So I do want to thank each and every one of you for your time. And just one second, I have a little housekeeping that I need to do. So I want to just say, as a reminder to our attendees, that you can gain continuing education credits for participating in today's session. To do so, please click on the link in the description below this window to complete the evaluation and to obtain credits. This information will also be distributed through a separate email to today's participants, along with the links to a recorded version of today's discussion and credit information. The email will also include additional HMS COVID-19 resources. Please distribute to your colleagues that you feel would benefit from this information. And I want to thank you all again for your questions in the chat that allowed us to have a full and fulsome discussion today. And I want to again thank our panelists for joining.